Good morning, everybody from London. My name's Anne Johnson. I'm Vice President International at the Academy of Medical Sciences, and I'm an infectious disease epidemiology at UCL. I'm really delighted to welcome you today to the Academy of Medical Sciences and Lancet International Health Lecture. This year, we're running it, of course, as a virtual event, and we all miss the opportunity to meet together in London. But one advantage is that many more of us have been able to meet from all over the world, and we have over 700 of you registered to join us today on this virtual platform to address a very important question, not just about the problems we face now, but what we can learn for the future. The Academy of Medical Sciences is UK's national academy, and our mission is to promote medical science and its translation into benefits for society. And the International Health Lecture is one of our keynote events throughout the year and provides a platform for leaders in global health to discuss issues of international importance. The lecture was established in 2004, and we're delighted that we're now in our 5th year together, holding it in conjunction with the Lancet. And I want to thank the Lancet very much for partnering with us to host the lecture, and particularly to Professor Richard Horton, editor of the Lancet, who will be introducing our speakers shortly. We meet on a day when we are in the UK due to go into lockdown for the second time. In July, the Academy of Medical Sciences produced our multidisciplinary report to the chief scientist called Preparing for a Challenging Winter. And at that time, we brought together our fellows from many disciplines to think about how we might avert some of what we are now seeing. Now, here and across Europe, we have to face the fact that we are looking at issues which reach our worst case scenario. So it's entirely appropriate that the title of this year's lecture should be Learning from Crisis, Building Resilient Systems to Combat Future Epidemics. And this year's lecture is unusual too, because we are bringing together 3 leading scientists to bring their perspectives together on this topic. They come from intersecting disciplines, underlying the emphasis that the Academy places on collaborative, cross-disciplinary approaches and international debate in finding solutions to global challenges to the health of the public. And our speakers today are Professor Gabriel Leung, joining us from Hong Kong, Professor Ilona Kickbusch, joining us from Geneva, Professor Shattock, joining us from London. Each of our 3 speakers will be speaking for about 20 minutes each, bringing us to an hour, hearing them give their presentations. We'll then move to Q&A for approximately 30 minutes, which will be chaired by Richard Horton in his inimitable style. And please do use the Q&A function to submit questions throughout the lecture, and we'll try to answer as many as we can. And please, if you could also give us your name, your affiliation, and where you're speaking from, that would be a great help too. So without further ado, it's my great pleasure to invite Professor Richard Horton, editor of the Lancet, to provide some introductory remarks and to introduce our stellar speakers.
Thanks very much, Anne, and welcome everybody. And Anne, you're very modest because you didn't say this, but you're also the president-elect of the Academy of Medical Sciences, and I just want to publicly congratulate you on your election victory. It's great, not just for you, but for the Academy and everything that the Academy stands for. I don't think the Academy could have a finer person to be coming in to lead it, especially at a moment of such a global health emergency. We have, as Anne has said, 3 tremendous speakers. Ilona Kickbusch is the founder and chair of Global Health Center at the Graduate Institute of International and Development Studies in Geneva. Professor Gabriel Leung is the Dean of Medicine and the inaugural Helen and Francis Zimmern Professor in Population Health, and he holds the chair of Public Health Medicine at the University of Hong Kong. And it was one of Gabriel's papers that we published on January the 31st that first spoke about the dangers of a global pandemic. And he's been on the forefront of doing some truly incredible research to guide the political responses to the outbreak. And Professor Robin Shattock is Professor of Mucosal Infection and Immunity at Imperial College London. And those of us in the United Kingdom will know that there's barely been a day when the name of Imperial College has not been in the media. We're meeting at a very strange moment. At the very beginning of this outbreak, there was a remarkable alignment, I think, in terms of the scientific response. I've never seen over my years at the Lancet the scientific community come together and work in such an unbelievably productive and constructive manner to address a global health emergency. Sitting where we sit, we've seen the extraordinary quantitative output, but also the incredibly strong science that has been produced and submitted to our journals across the Lancet. But as time moved on, as the year progressed, we saw several sharp debates cause fracturing amongst the scientific community. It began with what was the evidence around physical distancing, 2 meters, 1.5 meter, 1 meter, mask wearing, schools, should they be open or should they be closed? We got to learn more about the transmission of this coronavirus and understood the importance of aerosol transmission. And then the whole issue about the correlates of immunity and the risk of reinfection, and many other debates as we're looking forward around, for example, which vaccine is likely to come through first, and how effective or not effective will it be. And Tony Blair on the radio this morning seeming to suggest that corners might be cut, indeed perhaps should be cut, in order to get a vaccine used faster than we might have hoped for. If we look across the water to the United States, one of the finest physicians, infectious disease physicians in the world, Tony Fauci, who has played such an important part in guiding the global response to the AIDS pandemic, publicly vilified by a president in the most unbelievably outrageous fashion. We're at a moment where science has played such an important part in helping us to understand this pandemic. And yet there are serious questions about the way the scientific community works together, how it channels its evidence and advice to policymakers, and indeed the role of science in different political systems. Political systems such as ours, in a democracy, there are many advantages to democracy, but we have seen some of the disadvantages that democracies can bring in fostering often very conflictual debates around science in the policy-making process. I'm sure we're going to touch on some of these themes now. I'm going to start off with Gabriel Leung, who is going to give you his perspective from being on the front lines in Hong Kong. Gabriel, over to you.
Thank you so much, first of all, to the Academy of Medical Sciences and also the Lancet for inviting the three of us to give this year's lecture. And the title of this year's lecture is Learning from Crisis, Lessons from COVID-19 for Building Global Health Security. And I'm going to kickstart it. And the first thing is, of course, all of us still remember copying sort of memorable lines on the blackboard when we were at school. So I will learn my lesson certainly was one of those things that I had to copy many times, obviously for forgetting lessons. And let's take a look at a couple of fairly controversial items that we had, or we still are going through with COVID. So the first of this is about face masks. On the left, the graphic implies that face masks are a safety feature that could help us land rather more safely than without. But on the right, you have one of the major broadsheets shouting "End of freedom" about masks, about physical distancing, and other measures that have been imposed since the COVID-19 outbreak in various places. And of course, the upper panel on the right side is President Trump in the US, and with the Statue of Liberty, wearing masks in different parts of their faces, obviously. So let me try to sort of give you a little bit of the evidence to answer this question. Why did the WHO mask guidance change? So you remember that WHO, in fact, initially didn't really recommend face mask usage unless it's in very, very specific circumstances. And then by the middle of June, their guidance actually recommended much more general, liberal, or even universal face mask use. And if you actually look at the evidence pre-COVID, this is the evidence base on the effectiveness of face masks against flu in the community. So most of these studies, in fact, were funded by the US CDC, and we at the University of Hong Kong were one of those teams funded to look at this question of whether face masks and or hand hygiene were effective in reducing transmission of lab-confirmed influenza. If you look at the upper panel, you will see that there is probably some evidence of a limited benefit of hand hygiene plus face masks for confirmed influenza. But as you can see, the diamond in the meta-analysis forest plot actually traverses one. So if you actually look at these two diamonds, whether it's for face masks and hand hygiene or just masks, the point estimate of somewhere between 10 to 20% reduction in flu transmission associated with universal masking is plausible, although it's not definitive. Now, there was a rapid review published in the Lancet on face masks against SARS, MERS, and COVID-19 in healthcare settings, mostly. So you will see that there is, again, a forest plot. And then for the vast majority of those studies, in the top of that forest plot, they belong to healthcare settings, mostly hospitals. And then there were 3 studies for non-healthcare settings in the bottom. And then the overall diamond shows you fairly substantial reduction. Now, this shows you very strong effects in hospitals, obviously, but also even in the community setting, although not quite as strong. But actually, out of the 3 community studies, Lau et al. In 2004 refers to mask use when visiting a family member with SARS in a hospital, which is actually a healthcare exposure. So it's not quite community-based. And in the same review, actually, eye protection was supposed to be able to reduce SARS, MERS, or COVID by 75%. So probably a little bit of an overestimate. Now, if you actually look at mechanisms, and we use this so-called G2 machine, which was actually put together and sort of innovated by Don Milton, formerly of Harvard School of Public Health and currently at the University of Maryland. So Don and our team had been working for well over a decade on collecting exhaled breath, so 30-minute samples from outpatients with acute respiratory illness allocated to wear a mask or not. And then the exhaled breath was split into fractions that were above or beyond a certain diameter, i.e. trying to distinguish droplet spread from actually aerosol spread. And if you actually look at the human coronaviruses, and this is a paper that we published just a few months ago, it's not about COVID-19. It's about the 4 seasonal human coronaviruses, because clearly the work was done prior to COVID-19. But in both cases of droplets and aerosols, a face mask actually was able to completely stop the collection of particles, whether they are less than or greater than 5 micrometer or microns. Now, another piece of evidence, and this is ecologic evidence. So we've done repeated large telephone surveys of population behavior in Hong Kong, and we've found, as you can see in the red line at the top, that basically from the end of January onwards, it was basically universal masking in Hong Kong, looking at the right-hand axis. So prevalence of mask wearing is close to 100%, and it's not dropped. Yet, if you actually look at this diagram, there were still quite substantial outbreaks. First, in the March to April period, and then in the July-August period. Whereas actually we'd always been using masks throughout. So clearly other kinds of measures, including physical distancing measures, were responsible for actually bringing down the March wave of our outbreak, and then also the summer wave. So masks are probably necessary, or at least useful, but insufficient. Now, there is a very widely anticipated Danish trial of 6,000 adults randomized to wear a mask or not in the community. It's powered to identify a 50% reduction in risk, that is, from a baseline risk of 2% attack rate down to 1%. But a 50% effect size is probably quite unlikely, given what the earlier series of studies commissioned by the US CDC actually showed. We showed that probably it's compatible with a 10 to 20% reduction effect size, but probably not 50, which means whatever the results of this Danish trial shows, unless it's a very, very strong effect, it would be underpowered to actually detect a 10 to 20% likely effect size, because it's powered to detect only a 50% risk reduction. So the state of the science, I'm not going to read out all of these bullets, but to sum up, it's probably that a 10 to 20% risk reduction is likely. And if there is a trial, particularly the Danish trial, that comes out to say that it's not effective, then please look at the details more carefully to see if it's underpowered because of the 50% effect size assumption. And therefore, it would be fallacious to argue masks don't have 100% effect, or 50% effect for that matter, in stopping transmission, and therefore masks are useless. That's obviously wrong, because even a 10% reduction in transmission would be very, very valuable. And I'm going to show you that's probably what you get with school closures. Now, but that also means that widespread use of face masks, like in Hong Kong, would be insufficient to stop outbreaks completely. So it's probably a necessary but insufficient measure for COVID-19. It needs to be coupled with other kind of distancing measures. Now, coming to the second lesson, it's about school closure. Now, in fact, a lot of the early evidence about spread of directly transmissible respiratory pathogens like flu came from studies, observational studies in schools, whether it's at the very beginning, English boarding schools outbreaks, or more recently about probably, it's not actually published in 2020, that's a typo. It's published probably 15 years ago by Simone Cauchemez, who's now at Pasteur in Paris, to show that, yes, seasonal holidays in France show probably that there is a 16 to 18% risk reduction in flu cases. Now, we also looked at the same question of whether school closure actually worked. Again, these are all examples from flu. It's from the seasonal outbreak in 2008 in Hong Kong, from 2009, the pandemic, and then from 2018, another seasonal flu virus, flu B in this case. So in 2008, it didn't really work because it was too little too late. In 2009, it actually worked superbly well because it actually reduced transmissibility and also delayed the peak quite substantially during the pandemic. And in 2018, it had a very, very small effect. It probably reduced transmissibility by about 4%. So it's not certain whether it actually works. Now, for COVID-19, Mark Lipsitch from the Harvard School of Public Health and his wife, who was at the Harvard Education School, Myra Levinson, actually wrote a recent paper in the New England Journal of Medicine. And I'd like to just read you this quote. Whether and how to reopen primary schools is not just a scientific and technocratic question. It's also an emotional and moral one. Our sense of responsibility towards children, at the very least, to protect them from the vicissitudes of life, including the poor decision-making of adults who allow deadly infections to spiral out of control, is core to our humanity. Powerful words. In fact, the World Bank group, the education division specifically, modeled out what might be some of the adverse effects of school closures arising from COVID-19 and looked at these key outcomes, which I'm going to show you here. And basically, whether you are looking at learning adjusted years of schooling, whether you're looking at expected earnings falls associated with that, or whether you're looking at average PISA scores fall, or the share of students who would fall below a minimal PISA level that is desirable in any education system, you see very, very serious impact. So this is not just a health protection issue. It has got major, major implications that actually traverses the entire life course of those students. Now, there is a piece of evidence, again, at the ecological level, using an interrupted time series negative binomial model that was published in JAMA earlier on this year, just a few months ago, looking at actually the March school closure. So the first wave in the US, where all 50 states closed schools in this very tight mid-March period. Therefore, there was actually no positive or negative controls. But nevertheless, if you actually look at daily incidence or mortality and accounting for the time lag for school closure to work, you actually see a very nice inflection point in both the upper and the lower panels. But if you actually read the methods carefully, there was probably insufficient adjustment of co-varying non-pharmaceutical interventions, including a lot of physical distancing. And there is obviously very high correlation between school closure and other NPIs reflecting states' approach more generally. And therefore, the 60% or so incidence and mortality reduction are implausibly high compared to pandemic and seasonal flu. And I'm going to show you a comparative table in just a few slides' time. So this is still very much an unanswered question. Do school closures work? And do they work sufficiently well to warrant the anticipated negative outcomes that traverses the life course for children in education. So in order to answer that question, if we take a step back, you need to really think about agent host characteristics. So more specifically, age-specific susceptibility and infectiousness. What do they look like? What do the demographics of the population actually look like? Are they actually like a population pyramid, or do they more resemble an inverted pyramid? And what do the contact matrices by different settings, whether it's the school setting, home setting, or the work setting, actually look like? And therefore, all these actually feed into ultimately what the epicurve would look like. That is, how the epidemic or the outbreak is actually going to play out. So that's exactly what we did. This is a piece of work that is still under review. And we took very, very detailed and complete case contact data from Shenzhen, which is in Guangdong province in the south of China, just across the river from Hong Kong. And then we also took the exact same type of data from Anqing, which is in Anhui province, which is further north in the country. And we looked at, importantly, the relative susceptibility by age, which is panel C, and then the relative infectiousness by age, which is panel D. As you can see, relative susceptibility for younger age groups is actually a fraction. Probably for school-age children and young people up to the age of 20 is probably somewhere around 0.2, 0.3. Whereas relative infectiousness, it's probably flat because you see very wide confidence bounds. But if anything, it may be actually a little bit higher relative infectiousness, but not quite doubling it. Probably somewhere around 1.5, 1.6, 1.7. Now, if you then look at that and then use these synthetic contact matrices that were pioneered really in the Polymod project across many different countries in Europe, and it's led out of the London School of Hygiene and Tropical Medicine, and they've got a preprint, which is the most updated data that we used. And so if you actually do those two things, put those two things together, and then you run it through a transmission model, and you look at no age effect with the age distribution of susceptibility and infectiousness of either flu or COVID, and we take both pandemics 1 decade apart. Left-hand column is for the flu pandemic in 2009, and then the rightmost column is for COVID-19. You will see that for reduction in the R0, that is, if you close schools, what would your reduction in R0 be in percentage terms? For COVID-19, because of the characteristics based on what I just showed you, you would only probably be able to reduce R0 by maybe 10, 20, 20 some odd %, regardless of whether you are in a low, middle, or high income country. For the control threshold, that is, at what point would your R0 need to be, or RT need to be, in order for you to use school closure to bring it below 1? Again, for COVID, you can see that it would have to be pretty close to 1 already, maybe 1.1, something like that. And then you close schools, then you can bring it under control, that is below the unity value of 1. Similarly, what would be the equivalent reduction of infectious contacts in the workplace and the community, that is non-school settings, that you would need to do in order to substitute for school closure? For COVID, you can see that you don't really need to do very much. You can substitute school closure with many, many other interventions that would only need to be moderately reduced. Completely different picture on all these 3 key counts if you look at flu, because flu clearly is much more susceptible and infectious for kids. And that's really what the main message is. So it doesn't give you a very big bang for the buck if you close schools in COVID. And this basically is just looking at the data by age and looking at it another way, giving you more or less the same conclusion. Now, if you compare the reduction in R for pandemic flu, seasonal flu, during school closure and holidays, so we use our same transmission model that I just showed you, and then we actually reanalyzed all of these previous flu outbreaks to look at whether our model actually predicts things well compared to the published estimates. You can compare the two columns of numbers, and they look pretty good and pretty comparable. And in fact, if you then look at these numbers and then go back to that Olga et al. Paper in JAMA about the US 50 states and thinking back at the 60% risk reduction, you've never actually seen it with any of the previous flu outbreaks, which are supposed to be much more amenable to school closure as a control intervention. So that's why, after looking at this, you can probably surmise that the Olga et al. Paper, that negative binomial time series model, probably were overestimates because of insufficient control of other correlated measures. Now, there are finally some other lessons that I think still needs to be learned. That is the very famous Sweden model, Sweden versus Scandinavia, Sweden versus the EU, and then Sweden versus suppress and lift. And the rightmost column in the bottom is actually excerpted from a very recent paper that we put together with a very large group of international collaborators and published in the Lancet. So I'm not going to dwell on this slide, just to say that the verdict is not completely clear, although it is clear enough for people to have put together and signed up to the John Snow Memorandum, again, first published as a correspondence in the Lancet just a couple of weeks ago, in response to the Great Barrington Declaration, which, of course, is much more akin to the Swedish or the herd immunity approach, as opposed to the much more precautious approach of the John Snow Memorandum. Now, if you actually look at, on average, places that were hit hardest in the spring are suffering the most in the autumn. So it doesn't appear that the Great Barrington Declaration, or the so-called herd immunity approach, whatever that might mean, is actually the right way to go. And personally, I think that while the evidence still needs to be compiled and consolidated, all in the goodness of time, I am a subscriber to the John Snow Memorandum spirit. Now, there are other lessons that one really wants to learn, and that is, can you use testing, massively scaled testing, to compensate for other more draconian physical distancing measures? But you have to take into account reporting delays of tests coming back, quarantine arrangements once you get a positive test, and what about the testing frequency versus sensitivity issue, which is what this preprint is about. It's by the group led by Michael Mina at Harvard, really advocating massively scaled testing, not necessarily using the gold standard RT-PCR, but other platforms, whether that's the LAMP platform or even the antigen platform, and compensating for the lack of sensitivity compared to the gold standard by frequency. Now, also, what are the utility and drawbacks of contact tracing apps? So clearly, mainland China controlled their outbreak very effectively through a whole series of measures, particularly relying quite a lot, actually, on these health codes. Now, what about the search capacity of contact tracing? What is the comparative reflections with flu, and what are the implications for the future? Taking lessons, of course, from the Test, Trace, Isolate program in the UK, but also learning from the characteristics epidemiologically of the clumpiness of COVID. So almost 20% of COVID infections are actually responsible for 80% of all transmission events in Hong Kong, whereas 70% didn't really infect anybody else. So it's very clumpy, or in statistical jargon, it's highly overdispersed. So this is something that we showed in Hong Kong, but also we see very similar findings out of the London School also. So the clumpiness of COVID requires really zeroing in on very high risk venues. And if you actually get to that, you probably do a much better job in contact tracing. Finally, what can I say? But when will we ever learn these lessons? I'd just like to thank our funders who are in the bottom, and also the core team at Hong Kong U, who have been really indispensable to me being able to put together all these findings in this slide deck. Thank you very, very much indeed.
Thank you so much, Gabriel. That was a tour de force, taking us through a vast amount of important information, but with some very clear messages. Thank you. I just want to say to our 400 plus friends and colleagues who are watching this webinar that there were some problems with the quality of the slides that you may have seen. That's going to be corrected for the video, which will be available after we've completed the webinar on the Academy of Medical Sciences website. So if you'd like to go back and look at those slides, then you're most welcome to. Can I also encourage you to post questions that you would like to put to our panelists on the chat function of Zoom, please? We're already getting questions coming through, and I would love to see some more of those as we move ahead. Our next speaker is Professor Robin Shattock, and I'm really, really delighted to welcome Robin. Just very briefly, I mentioned that he's Professor of Mucosal Infection and Immunity at Imperial College. Robin is the Scientific Director of the European AIDS Vaccine Initiative. And of course, the reason why we've invited Robin to speak today is that he and his group are currently leading the development of a particular COVID-19 vaccine. So Robin, over to you.
Thank you very much. And I hope in this presentation to give you a forward-looking talk as to some of the challenges that COVID-19 poses in terms of vaccine development, but also to look at how things may change in the future. And I always like to start with this slide because I think it highlights some of the questions that people are asking around the globe, which is, when will they be able to access a vaccine? And depending on where they are in the world, how easy will it be for them to get a vaccine once it becomes available? And of course, the answer to that question is likely to be very different if you're sitting in Washington, DC or in Addis Ababa. And those kind of questions are exercising the global community. Now, of course, pandemics are nothing new to the world. And we have been really very aware that there are both emerging and re-emerging infections that pose global threats. And more recently, after the 2014 Ebola outbreak, that led to the establishment of CEPI, the Coalition for Epidemic Preparedness and Innovation, to be able to make vaccines developed, make vaccine technology more available, and to be active in pandemic situations. I suspect those who set up CEPI weren't anticipating that they would have to be pressed into action as quickly as possible. But one of the things that was already exercising the vaccine community after both the Ebola pandemic and then more recently Zika pandemics was, how should the vaccine community respond and how should it be financed? And in fact, prior to COVID-19, many of the large pharma companies were actually saying it was not sustainable for them to be called and pressed into action every time there was a pandemic that may have been of a relatively small size, but required massive investment, that they didn't have the funds necessary to support it, and often felt burnt having responded rapidly, but not necessarily secured markets that would return finance for the investment that they had to make to respond to those pandemics. Now, clearly, pandemics are something that are of increasing frequency and are very much related to zoonotic transmissions. And those seem to be occurring more frequently as we impinge on more and more of natural spaces, but also with the increasing density of animal stocks in terms of agriculture. And I suspect if anyone had to have bet before COVID-19 came forward, they would have more likely predicted that there may have been a flu pandemic rather than a coronavirus pandemic. Now, of course, really things have moved at an incredible space, but it was not that long ago that the pandemic was first seen to occur in Wuhan. And at that time, many of us were watching it and wondering whether this was actually going to be something that required a vaccine to be made, because there are outbreaks that often occur and then fade relatively rapidly. And so in the early phase, people were thinking of whether they needed to develop a vaccine for China rather than the rest of the world. And certainly the type of social distancing and other strategies that were implemented did have a profound effect in China in terms of curbing the pandemic. However, it was already out of the box in terms of spreading across the globe. Now, I think one of the really positive outcomes of the early phase of the pandemic was the publishing and making available the sequence for SARS-CoV-2, because that essentially allowed everybody around the world to start developing vaccines. And I think that this type of pace of revealing genetic code, sharing code, and allowing vaccine development is something both to be applauded and will influence the way pandemics are responded to in the future. Now, after that starting gun, essentially there has been a vaccine race. This is often alluded to in many different ways, both positive and negative, but it did mean that a range of different technologies got moving as fast as possible. And some of those are very new technologies, particularly the technologies in the RNA space, that because they use synthetic production approaches, were able to move very fast, very novel technologies, not yet proven in the clinic. And it will be interesting to see how those impact on the pandemic, both regular RNA and also self-amplifying RNA, a program of which I'm leading myself. But these are competing against more established technologies, such as inactivated vaccines, again, that have managed to move very fast. So perhaps older style technology and viral vectors. Now, all of these have different strengths and weaknesses and can get to the clinic with different timelines. Now, of course, we don't know right now what level of immunity or type of immunity is required for a vaccine to be effective against COVID-19. And later I'll move to what do we mean by effective against COVID-19. But the important point to recognize here is that at the start of clinical development, most vaccines have about a 10% chance of success. That means 80% of vaccines are actually quite likely to fail. Now, we don't know whether that's going to be the case for COVID-19. If a small amount of immunity tips the balance between serious disease and mild infection, it may be that the majority of vaccines will work and have a role to play. But if a particular type of immunity or a very high level of immunity is required, then we may see that only 1 or 2 vaccines come forward as protective vaccines. And of course, there will be different levels of efficacy and effectiveness for vaccines as they come through, and managing that may be very complicated as these vaccines become licensed. Well, a second really success of accelerating efforts against COVID-19 was a lot of structural biology and work done against SARS and MERS, particularly in understanding the stability and conformation of the surface glycoprotein. And this allowed people to move ahead very quickly, identifying the sequence of COV2's glycoprotein, but also to be stabilizing it in a pre-fusion conformation. Now, whether the extent to which this is required to give high levels of neutralizing antibodies will continue to be debated. But I think that this shows how dissemination of this information allowed many developers to move extremely quickly, and is another big positive. Now, this slide really is very nice in terms of comparing and contrasting the rates of vaccine delivery and development. The top line really shows traditional vaccine approaches, which are a multi-year process and often require billions of dollars of investment. Now, one of the reasons they take long is partly because they require increasing investment over time, but also because people want to be as sure as possible that they have success and safety. And so therefore, it's better to get the vaccine approach right than to move too fast. Now, COVID-19 has exercised the world to move as fast as possible, with many of these phases moving in parallel and with very close interaction with the regulators. And again, that interaction with regulatory authorities has been a significant benefit in terms of development of potential vaccines against COVID-19. What it does do is pose some challenges and questions in terms of public acceptance. One of the perceptions is that corners may be cut, and therefore these vaccines may not be as safe as vaccines developed along traditional timelines. Now, those concerns are both valid and not valid, because the number of individuals that are being used in these phase 1 through phase 3 trials is of a similar number to those in traditional vaccine development. It's just been done in a faster time frame. However, what we won't have is long-term stability data, long-term safety data for these vaccines. So once they're rolled out, it will require ongoing safety for a number of years to increase the safety database. What also will be challenging is that we will know the duration of protection and effectiveness during the time frame of a clinical trial. So if a clinical trial is only conducted for a 12-month period and people are getting that vaccine during that 12-month period, we will only have efficacy data for that time frame, and we won't know what the efficacy is over a longer time frame. And that may cause complications in terms of how these vaccine candidates are rolled out and used globally. Well, the success of the vaccine race is the explosion in terms of candidates. We know that there's over 151 candidates in preclinical evaluation, and quite likely more, but a number of candidates already in late phase 3 efficacy trials. Now, whether we need 151 candidates and whether most of those will just stay in the preclinical space will really depend on the success of those candidates that are ahead in the queue. And you can see that these candidates are a mixture of inactivated viruses, viral vectors, protein subunits, and RNA. And so to some extent, we will also see how these different technologies compete against each other, both in terms of demonstrating efficacy, but ultimately in terms of their potential for rollout in a global setting. Now, by and large, all of the vaccines that are in the first wave are traditional vaccines that require needle injection. And one of the big unknowns is whether they'll be effective against disease or against transmission. And of course, COVID-2 is a respiratory transmitted virus, And so we don't know whether it may require higher levels of mucosal immunity to block transmission, something which parenteral vaccines are perhaps less good at delivering. And so we may see later waves of looking at mucosally delivered vaccines if we truly want to block transmission rates. Now, I think one of the things that's important for us to recognize, and clearly isn't widely recognized by the public, is what will success look like? And as we think of success, we have to recognize that all of the current phase 3 vaccines are testing as their primary endpoint their ability to modify disease. That means to prevent hospitalization, severe disease, and fatality. Now, of course, in the absence of any vaccine, a vaccine that has any impact on severe disease would be highly valuable. Of course, that will mean that potentially there may be more asymptomatic infections if they don't block transmission and only prevent against serious disease. Now, ultimately, a vaccine that can prevent against all infection and block transmission would be the most effective in controlling the pandemic. However, this is a significantly higher hurdle to demonstrate and a higher hurdle for a vaccine. So what I anticipate is we'll see different waves of vaccines coming through as they reach regulatory approval. The first are most likely to be disease-modifying vaccines. The later ones may, we hope, have efficacy against preventing infection and transmission. But ultimately, as we think about these being rolled out globally, the other important considerations will be the ability for rapid scale-out, their cost, and their ease of administration in the field. Now, the complication that we anticipate is that if there are multiple vaccines showing different levels of efficacy and introduced along different timelines, how can that actually be managed in a population? One of the largest complications will be understanding the duration of protection, whether that's against disease or infection. If you imagine that you have 3 new vaccines that have different timelines of efficacy and protection, how will that be monitored in a population? How will any health system work out who to call back when for a booster vaccination? So again, these are things that are being thought about, but so far there isn't a foolproof plan for thinking about how to roll out vaccines with different levels of efficacy and different durations of protection on a country level, and even more importantly, on a global level. So we still are hopeful that the first vaccines could show efficacy by the end of 2020. Again, I think in terms of public communication, we need to avoid people thinking that the day they wake up and hear news that a vaccine has shown efficacy does not mean that that vaccine will be available immediately, nationally or globally. It's likely that we'll start to see potential rollout in the first half of 2021, but even to reach vulnerable populations, that's not going to be something that's achievable quickly. We also will need to understand how often a booster may be required, whether this is an annual booster or whether vaccines can give protection for a much longer period of time. And again, the unknown here is whether a small amount of immunity prevents disease and prevents reinfection causing disease versus the level of immunity that would be required to stop transmission dead in its tracks, and which types of those approaches are most effective for rolling out globally. I think it's widely recognized that in a first phase of rollout, there will need to be prioritization. And that prioritization is likely to be prioritization of health workers and those that are in vulnerable populations. Now, of course, vulnerable populations are a mixed bag in that not all vulnerable people respond well to vaccination. And therefore, we may also have to think about strategies where we ring fence the vulnerable by ensuring those that are both professional and non-professional carers are also immune to the virus. Well, the other thing that's important, and again, not widely understood, I believe, by the general public, is the level of efficacy or effectiveness. It's very unlikely that the first vaccines against COVID-19 will offer 100% efficacy, and all of the vaccine trials to date are powered to detect vaccines that are 50% efficacious. It's also important to remember that the influenza vaccine, that's the seasonal influenza vaccine, depending on the study, is about 40 to 60% efficacious, and its efficacy variables, it varies according to the age of the population. That vaccine still has very important public health benefits and prevents health services from being overrun. So a high level of efficacy is not necessarily required to have an important public health benefit, but still may have difficulties in providing efficacy against transmission. And this relatively simple cartoon just reminds us of what might be required if you have some vaccinated individuals, but not enough to provide a level of herd immunity. That's still not going to block transmission. And we don't know the level of both efficacy and the implications that that may have for the level of the number of individuals that may require to be vaccinated to actually block transmission. It may well be 70% or higher of any population, and delivering that may be a challenge, both in terms of the challenge of delivering the vaccine, but also in public acceptance, remembering that most of the public still will only get mild or asymptomatic infection. So we're asking populations, in the general population, to receive a vaccine that will be protecting others. So a bit like wearing face masks, it will be for most people an altruistic vaccine. And that has important implications in terms of the risk-benefit analysis and in terms of the level of tolerability. Somebody who is at risk of a vaccine may be more likely to accept a vaccine that has side effects that are unpleasant, but gives you a high level of protection, versus those in the wider population that are taking the vaccine to block transmission. And then it's important, obviously, to recognize that distribution of a vaccine is a challenge for any vaccine. And some of the new technologies that are coming out and are very rapid may struggle with the requirements for cold chain and wide-scale distribution. And so we may see vaccines that are of high value and can be moved into high-income countries that are not necessarily appropriate for low and middle-income countries with hard-to-reach communities. Well, we hear a lot about vaccine nationalism and both the positive and negative impacts of that. I think it's very important to recognize that vaccines don't get developed without significant investment. And so while we see some concerns raised around advanced purchase agreements, these have been extremely important in actually providing a potential market space that has been the pull for many of the large pharma companies to respond to the COVID-19 pandemic. And strategies like the Warp Speed funding in America have been instrumental in getting large-scale efficacy trials in play. However, to provide global access, it will be important that there are organizations like COVAX committed to making 2 billion doses of vaccines well supported. Now, 2 billion doses of vaccines in a year is an enormous challenge. But remember, that will not be sufficient to provide enough vaccine to have a major impact on transmission. It will have an impact on disease and fatalities. And in that context, we need to be very conscious that there is still a lot of anti-vaccine movement around there. And this may be accentuated by conspiracy theories about COVID-19. And so we need to make sure that we are very careful about the communication of the safety of vaccines, And also recognize that as soon as a vaccine is available and works, if it's not globally available, there will be potential counterfeit vaccines. Those may have safety issues, and it will be important that all COVID vaccines are not necessarily labeled with any safety issues that might occur with a particular type of COVID vaccine. A lot of discussion has gone on about whether the virus is mutating. And the good news is that COVID-19 does not seem to be changing in a way that it would evade current vaccine candidates that are in play in late-scale efficacy trials. But we need to remember that that's in the context of a global population that's naive to this virus. Once levels of immunity, whether they're natural or induced by a vaccine, come into play, that may start to change the virus. And so we do need to be prepared to have next generation vaccines ready to be put into play should the virus change over time. Well, thinking very quickly about the future, the current paradigm has been very much large pharmaceutical companies coming into play, making vaccines and looking for global distribution, either from central hubs or then starting to contract manufacturing with other parts of the world. It's clear that one thing I think that will be changed if we reach a post-COVID era is that many countries around the world that have been standing in line for a queue for a vaccine will be starting to think about establishing their own vaccine manufacturing facilities. If we see some of these new technologies, particularly technologies around nucleic acid vaccines, showing to be effective in this space, I think that this will be game-changing in that many of these technologies can be transported around the world and put into a low footprint, low cost setting. And so ultimately, when we think about preparing ourselves for the future, for the next pandemic, we need to be thinking not only about having networks for surveillance, networks for distribution, but potentially moving to technologies that would allow vaccine manufacturing to be able to be set off in multiple parts of the globe, rather than relying on single manufacturing centers or few manufacturing centers in particular parts of the world. And this is probably the only way that we may be able to change the current paradigm. So I think as we look forward to future pandemics, many countries are looking to how they can both accelerate access to vaccine candidates in the future, but also be able to have their own independent processes so that they don't have to wait in queue for large pharma to come to their rescue. And I'll stop there and thank you for your attention.
Thanks so much, Robin. That was a wonderful introduction for everybody to the very challenging question of will a vaccine be available anytime soon. There was a paper published in Nature Medicine recently that was also looking at vaccine hesitancy across, I think it was 19 countries. And there was something like 10 to 20% of people were expressing views suggesting that they might be skeptical about a vaccine. So it's a very live issue, and perhaps we could pick up some of these questions when we come to the Q&A. Now, I'm very, very much delighted to introduce our third speaker, a long-standing friend, Professor Ilona Kickbusch, based at the Graduate Institute of International and Development Studies, which she founded in Geneva. She's a member of WHO's Global Preparedness Monitoring Board and the High-Level Independent Commission on Non-Communicable Diseases. She's also co-chair of Universal Health Coverage 2030. Importantly for me, she's co-chair of a Lancet Commission on Governing Health Futures, growing up in a digital world. So Ilona, it's a delight to have you with us. Over to you.
There we go. Thank you very much, Richard, and thanks to everyone who's listening to us. I will be speaking about lessons that we have learned politically, or maybe I should say are hopefully in the process of learning politically. because there are many large-scale political issues at stake that we need to face in global health and beyond global health, how we organize our societies and how we organize multilateralism. So there's a big agreement that we do need transformation, we need a change, and we need to move away from a range of issues where we think that globally we can avoid risk and rather think, as Mariana Mazzucati highlighted very much, that we must share risks. And in order to share risks, we will also need to share wealth and we will need to share power. And this is an issue that we will need to face with in global health. If we look at some of the failures, and I see failures as this larger issue rather than mistakes we actually made as we were trying to respond to the pandemic, because obviously if you face a new virus, you will also make mistakes. But I think there are very big failures that we need to face up to. And if I say we, I really mean this part of the world. I live in Switzerland, I speak from Europe. And here I would say we have to look at two forms of magical thinking. One is that any kind of pandemic is about them and not us. And that kind of magical thinking, of course, led to much of the European countries reacting too late. It also applies to the United States and some other countries. And it was a sort of dominant narrative about who is advanced in their thinking and who is backward. So there was a lack of learning from countries, particularly Asian countries, who responded very quickly, who did a whole range of things to make sure that the pandemic could be controlled. And it was a very strange understanding of whose knowledge is accepted and whose expertise is accepted. There is, of course, another form of magical thinking around conspiracy theories and others that politically we have to face with. Other failures, of course, are also very, very political. The whole notion that, you know, the first response was we have to save ourselves and we forget everyone else. It was very clear that we had a failure in global instruments and global institutions and an increasing feeling that our multilateral organizations were not up to the challenge. And of course, like in so many other areas, the virus clearly showed those fault lines in our societies, in our organizations, in our international corporations. But not only in our health organizations. And one of the things that's already been alluded to is that, of course, it also showed fault lines in many other areas of society, of politics, and of multilateralism, last not least, the international trading system. What's important to keep in mind is if we talk of failures here, these are obviously not things that came out overnight. These are failures in the way we organize our cooperation internationally over years, if not over decades, where we were not willing to face up to some tough decisions that we might have had to make. So lesson one, I think, is we really have to analyze continuously just how political the responses to this virus have been. We have heard from the two previous speakers all the excellent academic work that is going on, the scientific progress that has happened along the last months at a speed that we could never have experienced before. But what we have seen is that all these, in quotes, scientific technical solutions have not been sufficient, and that we must really use the lessons from this crisis to revisit multilateralism and revisit the instruments that we have at our disposal. And therefore, we do have to revisit what we now call the political determinants of health and the power relationships in global health. And we have to look at the venues and the methods through which this power manifests itself. And of course, already, as we have heard, around populism, nationalism, etc., that stands in the way of international solidarity. The second lesson is one that is going to be very painful and that we have to look at very closely. At first instance, particularly in the context of earlier this year and the first wave, we had the feeling that to some extent democracies could respond better, at least that one type of democracy could respond better. Democracies that were not populist, that were not divisive. What we're seeing now, though, is in the second or third wave, depending how we want to define it, that some of that is becoming unclearer. And we really need to revisit the extent to which our democratic systems are prepared for emergencies, for emergency response, and how we can ensure that democratic processes and democratic rights that we have in our societies are maintained. And I've been very intrigued that as many colleagues have been discussing, how do we involve communities, what kinds of literacies do we need, and how do we respond to infodemics, that we do speak about health literacy, we speak about digital literacy. But one thing we are finding is that the neglect in our societies of civic literacy, that people really understand how our democratic system works, that they really understand how they can participate, and one might even say how they must participate, creates a very big push to actually reconsider the extent to which a pandemic response is actually also a response that strengthens democracy, that strengthens trust, and that actually ensures that our democratic system is maintained. We've seen in some of the Western democracies that actually initially populist parties were not able to dominate the situation. We've seen, for example, in Germany, that there still is a very high trust in the government. But then the question also is, over how long a period of time is one able to maintain this in democracies? And you will all know this long discussion about pandemic fatigue, and to what extent in democracies we are willing to keep up a certain amount of solidarity. I think as we look at the pandemic, we also have to analyze much more clearly this interface between risk and power. And that includes the interface between science and politics, something that's already been alluded to. And we also have to look very much more at the disparities that emerge. One of the big disparities that have always been highlighted during this pandemic has been the gender disparity in decision-making, the gender disparity in who is most affected, both directly and indirectly, and of course, the gender disparity in those that care for us. And so in a strange way, from a political perspective, it is not true that viruses do not discriminate. They actually feed off the political, economic, and social flaws in our societies. and so take on features of those respective societies. And that is why we have to do a very in-depth analysis of how power manifests itself during a pandemic. Just two things to keep in mind, that in this context, we are experiencing both economic blowbacks and political blowbacks. One economic blowback, obviously, is the extent to which poverty is increasing worldwide because of the pandemic. And of course, not only in the poorest of countries, but also in many of the so-called rich countries. The other big blowback is the one that we are experiencing politically in multilateralism. There's been much analysis of, the drawback of the United States from the WHO, from other international institutions, the way they have acted in G7 and G20 negotiations. But we are probably now facing a very big standoff in relation to the World Trade Organization. And the World Trade Organization will play an incredibly important role in relation to access to vaccines, therapeutics, and diagnostics in terms of the TRIPS obligations. And as some of you might know, there's that India and South Africa asked for a temporary waiver of the TRIPS obligations for at least as long as the pandemic is underway. So we are stuck that the power relations also in this critical organizations manifest themselves and will have a tremendous impact on everything that the speakers before me have said in terms of access to vaccines, therapeutics, and diagnostics. The fourth lesson, of course, is that the pandemic is not our only global risk. And I was really intrigued when I compared these two pictures. One, of course, is the coronavirus. Another one is an attempt to show the urbanization of our planet. And you can see how close they are, and that actually also during this pandemic, we realized that in terms of pandemic preparedness, we had neglected to work together closely with urban infrastructures, with mayors, with urban decision makers. But I think we must take up the issue that, also the Lancet as a journal has discussed so significantly and regularly, what actually in terms of living in the Anthropocene means in terms of the accumulation of risk, and that the pandemic is only one risk that we face, and maybe because it affects us humans so quickly and so directly, one that we are willing to look at more rapidly than maybe some of the others, like the ecological risks. So one notion that I think we will have to live with more, and a concept we should work with more, is that of the Global Risk Society that was developed by Ulrich Beck some years ago, and is centered around what we call manufactured uncertainties. And that is the extent to which we also have to live with these uncertainties, that we cannot calculate them, that they are very delocalized, and that it is not the type of risk in our insurance model thinking that can be easily compensated. I was very intrigued when Seth Berkley, who is responsible for moving the COVAX initiative ahead, actually made a comparison to say that COVAX is the biggest multilateral effort since the Paris Climate Agreement. And I just put next to one another the countries that have agreed to the Paris Agreement and the countries that have since joined COVAX. And of course, you see on these two maps that one of the biggest and most important countries has well, first of all, left the Paris Agreement, and second, has not yet joined COVAX. And I think this is so pertinent because both ventures really call for collective action regarding a common good, a global good, as many of the speakers at many of the large public events around establishing COVAX, for example, have said. Lesson 5, of course, then leads us right into something that I think needs to push us to some extent beyond the SDGs. We have to discuss what is actually a rights-based global contract and how should that be discussed in different political venues. The Director General always says no one is safe until all are safe. And there are many elements to increase that security and that safety that we must look at. I've listed them all here, or some of them here. I'm not going to read out all of them, but definitely there are financial mechanisms like debt cancellation, a new mechanism to finance global goods, a new understanding of what WHO should actually be doing, and of course, something that health experts have always pushed for, and that is that universal health coverage must be in the center of any such global contract. I think we have 2 solidarity test cases in terms of global goods. I don't need to say much about COVAX, you have just heard about that. But many people say that for multilateralism, the distribution of vaccines will probably be the defining issue that we will be facing in 2021. And if we have a continued increase of infections in the developed world, I am very, very nervous, very worried how this distribution discussion is going to move on politically. So the willingness to share risks and the willingness to share goods is then, I think, definitely going to go down. But something we don't discuss enough in terms of sharing risks as a global common good is actually the whole issue of data, information, and intelligence. Beyond pandemics, there is a much wider issue of cyber biosecurity vulnerabilities that we need to look at and that we will be faced with. And it goes far also beyond the infodemics that we have been looking at. And I think one of the challenges, and that relates also to the commission that I'm working in, is really what, as a global common good, are global open source systems, pandemic alert systems that we must share, that not one intelligence service keeps to themselves for nationalist reasons. And here the issue of health data, issue of maybe a type of health CERN is something that is incredibly important as a common good and that we must think more about. To round up, I think one really important thing is to think beyond the present crises. And this is something we also said in the Global Preparedness Monitoring Board. We are always preparing for the last crises. Obviously, we're still in the middle of this crisis. But, you know, when we were talking preparedness, we were thinking Ebola, we were not thinking forward, we were thinking maybe flu, we heard that from the other speakers. But we really have to say now, and that is related again to that notion of pandemic alert system, how do we have a better multi-sectoral risk alert system, and what then are the anticipatory triggers? What is it that as a risk bubbles up in such an alert system, where we can respond quickly, where we align responsibilities, and where we are willing to move forward in terms of collective preparedness. So we are facing a larger transformation of our global system, of our risk-sharing system, of our information systems, and preparedness systems. And that, in a sense, I at least believe, can only be handled through a multilateral approach. The GPMB has proposed a preparedness framework that needs to be developed, that needs to be multilateral, that needs to be multi-sectoral. We have to take that kind of thinking forward. And if anything, that would be then the third type of global public good that we would need to develop to keep the world safer. So to round up, I think we are navigating a very, very changed landscape. It's a landscape where we cannot look at human health separately from many of the other things that are going on, from many of the other human and planetary risks. There are some models out there how we can think that differently. This is the famous donut model that allows us to bring together different forms of risk and development and actually try and address them in a joint way. And I would hope that many in global health thinking would move towards that kind of integrated thinking. We are seeing first cities and first countries actually trying to adapt the way they run their cities and countries to such a model. And that's the kind of transformation and future thinking that we need. But even as we move forward there, we need to be incredibly aware of the increasing inequalities that this pandemic is now bringing to the world again. We will not reach the SDGs, and we will see that this increasing poverty, inequality will again be related to what kind of new relationships will there be between risk and power and between risk and inequality. The risk of catastrophe, says Ulrich Beck, haunts the poor. They are the ones that are most affected. And I love this cartoon because it also shows what has been discussed as one looks at the stock exchange and sees, you know, the amount of wealth that has been collected in these months of the pandemics by people who are already extraordinarily rich. And that inequality is something that we definitely need to address. The Director General of WHO says continuously that health is a political choice, and it's those political choices that we need to work on both nationally and internationally. Thank you very much.
Thank you so much, Ilona, for that fabulous talk. You took us through the acute failures that we have faced, but also you gave us a very constructive and hopeful vision for how we might write a different future. So thank you. We're going to spend now about 15 to 20 minutes or so in a discussion. We've got lots of questions coming in. Some of the questions are very specific about aspects of the talk, but I'm really delighted that we've got such a global audience. We've got questions coming in from Nigeria, from Sri Lanka, and we've truly got an international attendeeship, let me put it like that. But one question I want to come to for all three of you, and you've all mentioned this issue, and we need to reflect on it a little bit further, I think, and that's the issue of trust. I think at the beginning of the year, when this hit, as I mentioned in my opening remarks, I think there was a remarkably high initial level of trust. We really did feel as if we were all in this together. And there was, at least I was seeing, a high degree of solidarity. And that, in some countries, that appears to have held. A country like New Zealand, for example, Jacinda Ardern winning an increased majority in the recent election. But in other countries that we don't need to perhaps mention by name, trust has really broken apart. And I wonder how we in the scientific, medical, health policy community, how do we analyze that? Gabriel, coming from Hong Kong, I mean, you were close to the epicenter. How do you see the issue of trust from where you sit?
I think if you go back to the very early days, even before COVID-19 got christened as COVID-19, there was a lot of skepticism around the world, and perhaps even within China itself, during those first few weeks. But I think that as China brought the Wuhan outbreak, and also in the rest of the country, those first and honestly the only waves in the country under control, I think it earned a lot of trust, certainly domestically, and increasingly internationally. Now, of course, earning that trust has been a difficult task, not least because it was the original epicenter. And I think that that's the kind of thing that, having had the imprinting by SARS, East Asia more generally, so the Eastern Hemisphere, stretching all the way from China down to Australasia, I think that you see a very, very different kind of response. And I think that the sociological imprinting and then the demonstrable building up of trust from that initial control effort has done a huge amount. And I think that that's probably something that East Asia could share with the rest of the world as we now head into the second and the third waves.
Absolutely. Robin, trust must be central to your work, as you alluded, in terms of building confidence for a vaccine. There's a wonderful book called The Age of Misinformation that was published last year. And one of the issues that's raised in that book is, how do we try and build trust in science? And one of the questions that the authors posed was around the relation between scientists and industry. And I wonder here, I've seen conspiracies, yes, but concerns raised about the role of industry in vaccine science. Do you see that as a cause for concern, or how do you think we can retain the public's confidence as we have the first wave of vaccines, hopefully in the early part of next year?
I think it's going to be a very delicate balance. It's clear that without these large vaccine partners, the infrastructure wouldn't be there to generate the vaccines. So that's been vital. I think there's a danger that politically there's been a hyping of a vaccine will get us out of this predicament, and there's a danger that the public will be disillusioned when a vaccine occurs and it doesn't change things overnight. I think the other danger for vaccines in general is that once a vaccine is rolled out and COVID-19 no longer seems to be a global problem, if the whole world gets a vaccine, there are going to be lots of people who think that that vaccine causes other health implications. And so it will be an incredibly complex piece to say that people are not suffering from things that they would have caught normally, are not associated with COVID-19 vaccines. And that, I think, is going to be a huge public relations piece in the years to come.
Yeah, absolutely. That's a very important point. Ilona, I mean, from where you're sitting in Geneva, I mean, one of the tragic elements is the fact that there has not been the willingness to cooperate, as you underlined, and the often fearful attacks on the World Health Organization, completely unjustified, in my personal view anyway. I think that the WHO has performed astonishingly well in January, and the leadership by Dr. Tedros has been exemplary. But clearly, in the eyes of some, it's easier for governments to blame a multilateral organization and take responsibility themselves. And it feels as if the global system, as you pointed out, really has fractured. How are we going to rebuild trust in the coming years? What can we do?
Well, Richard, I think there is a ray of hope, obviously, and that ray of hope was clearly shown in May of this year at the World Health Assembly. And what one does see, you know, in this geopolitical standoff that we have now, usually, at least in politics, if there's a vacuum, somebody else steps in. And I must say that at least I am reasonably relieved that the European Union decided to step in. And we've seen clearly that the European Union, together with African countries, with the African Union, with many of the Asian countries, because remember, in parallel, there is an alliance for multilateralism, an alliance of middle powers that come together to say, we've got to save this system. So it is that alliance that is coming together, that also in the G7 and G20 has been discussing the reform and the strengthening of WHO, actually saying it needs to be more independent, something many of us have said for a long time. Now, when the push comes to shove, let's see what happens. But I think there is a silver lining right now, that the crises that emerged from the behavior, in particular of the United States, has really gone right into the bone of many of those who were always supportive of multilateralism, but sort of sat on the sidelines. And I think here we're seeing a tremendous push. The Council of the European Union has draft conclusions all about strengthening WHO and helping it gain that stronger independence. So I hope that is something that one will be able to take forward. And I might say what we are starting to see is another type of leadership, not this gung-ho thing, we are going to lead all of you, but, you know, let's work together as strong partners from different parts of the world to actually find a solution to this.
That's also very hopeful. Yes, I mean, now we do need groups of countries working together, and if the European Union can step up to that role, as you indicate that it is beginning to do so, that's very encouraging. I want to look at this pandemic from a slightly different perspective, if I could. We've tried to argue in the Lancet that it's not a pandemic as such, it's a syndemic. And by that, I mean a synthesis of multiple epidemics, in particular, the virus is hitting populations that have underlying risks, in particular, chronic disease. And then there's a social patterning as well, that it's a virus that accentuates and exploits and exacerbates inequality. And so if you put those biological and social factors together, it's a much more complicated challenge than perhaps we are. It's already a pretty tough challenge as it is, but actually it's an even more complicated whole of society challenge than perhaps we've acknowledged so far. And I wondered what you thought again about that, and again how, as a medical health and health policy community, we should be trying to shape the debate around the social dimensions of the pandemic as well as the biological dimensions. Let me start in reverse order with Ilona this time.
Well, Richard, I couldn't agree with you more, and I hope I indicated some of that in my talk. And I think, we cannot deal with pandemics or understand pandemics without the social and the political dimensions, because in order to establish social protection systems, you need political decisions, be they national or global. And that's why our Global Preparedness Monitoring Board has also said there can be no health security without social security. So the issue is obviously the starting point are many of the social determinants of health, those enormous gaps in our societies that the virus has really, shone this light on. And of course, those people who are most suffering from diabetes, from all kinds of NCDs, again, are those people that are neglected, that are vulnerable in our societies. But I think what we've also learned beyond our older understanding, if I can call that, of social determinants, we are seeing, issues like racism come to the fore to an extent that has not been part of the global health debate or a national health debate so far. So I really think, these interlocking vulnerabilities, and that's why I put such a focus on power. This is about power. It's about money. It's about patriarchy. It's about those kinds of issues. And so I couldn't agree with you more. And that's why I said, we need a larger transformation.
Yeah. And Robin, when we think about the vaccine, you alluded to this at the end of your, towards the end of your talk, the people who need to get access to the vaccine are sometimes the people who are most socially excluded and at the margins of our society. And of course, if we put the pandemic in a truly global context, we haven't talked about Africa or Asia or Latin America very much. It has been rather a lot about us in Western Europe. Perhaps understandably, how are we going to build this solidarity, thinking more broadly about this as a syndemic rather than a pandemic?
I mean, it's certainly been very challenging, and traditionally we thought about vaccines in terms of childhood vaccines being the most important, and they still are critically important. And I think what's surprising about this pandemic or syndemic is the fact that it really doesn't seem to be causing disease in younger generations, and it's very much focused on the elderly. And of course, in some parts of the world, there's an increasingly elderly population, and we're going to need vaccines for those populations that may be particularly difficult to induce good types of immunity. But it also suggests that globally there may not be a requirement, particularly in places like Africa, for mass vaccination. I suspect we will move to really focusing on vulnerable groups. And there is a danger that if we go for a global strategy, it may well distort the distribution of vaccines that are badly needed against other diseases. Shortages of glass, shortages of health workers, clogging up the system with trying to get a COVID vaccine to everybody in the world may not necessarily be appropriate. And to be honest, it's a relief that this isn't a vaccine that is hitting younger people in those poorer countries where the demographics are that there's many more people in a younger generation than an older generation, or we'd be looking at a much higher fatality rate.
Yeah, but I mean, we still need countries to work together to come up with that kind of plan, though, don't we? I mean,
absolutely.
Okay, and Gabriel, from your perspective.
Right. So let me just pick up on that vaccine distribution and allocation. We have already seen COVID-19 imposes itself as the gravest single health event in recent memory. And that's mostly by omission. That is, it's the nature of pandemics to hit those who are most vulnerable. And it's because governments and the global community have not done as much as we perhaps should have. And so I think that's already been done. But I think going forward, it's a true test of what it means to have global solidarity in terms of, are we going to commit yet another grave inequity by not having a plan of vaccine allocation, distribution, and inoculation. It's a very, very difficult task to try and get vaccines into the right arms. And so I think that this is a true test, not just geopolitically, but also at the regional level and at the subnational level. And that really, I think, is going to be one of the huge hurdles that we've yet to even have a proper plan to overcome.
Thanks very much, Gabriel. Well, look, it's in London, it's 20 minutes past noon, and we've been going almost 2 hours, and I want to draw a close to the discussion, but I want to thank you, Gabriel, Robin, and Ilona for a really fantastic set of presentations, thoughtful, concise, really sharp. So even though it's been a challenge planning this, you've really delivered way, way, way above any reasonable expectation. Thank you. I'm going to hand back to my partner in crime here, Anne, and I just want to thank our technical team behind the scenes who've made this possible, because they've done a super job. Anne, back to you. Thank you.
So it's time to finish. I could stay here for another hour. It's been absolutely fascinating. For all of you who've been watching, and there've been well over 400 or 500 of you, and many of you have stayed right to the end, which is fantastic. Just to let you know that a video of the event will be available. We'll get some improved quality slides to you, because I, for one, will be poring over all this data for some time to come. We asked the three of you to think beyond the present, and my goodness, you've done that. And although we deliberately asked you to come from several perspectives, and as I started at the beginning, that is absolutely at the heart of the Academy's mission. I think we've seen here how the intersection of science, health, and socio-political issues are just inextricably linked. You've given us some great lessons. You've shared a lot. I would wish we could spend more time doing this kind of international sharing, which all of you have emphasized has been lamentably, I think, inadequate in this pandemic we're all facing, where nationalism has so often dominated, and I think sometimes blinded us to what we can learn from others. So I couldn't emphasize more the importance of global cooperation. The importance also, which has really come out, of inequalities, and how every pandemic does really emphasizes inequalities in health. And I know Richard's been reading this book, but I've been reading about the 1918 pandemic. And if we want to learn lessons, we can go back 100 years to see exactly how these societal fracture lines emerged, how issues of democracy, politics, and immense inequality arose and caused exactly the kind of dissent, disruption, and reaction that we are now seeing world over on some of the things that you've mentioned. I really would like to thank Gabriel, Ilona, and Robin for outstanding contributions. We'll be working with them to bring together the learnings of these so that we can share all that with you. I must thank the Lancet for collaborating with us to hold the lecture, and of course, Richard Horton in particular for chairing the event. We couldn't answer all your questions. There were many of them. I know Richard got his eye on the chat function, trying to bring together many of your comments, which he was putting there in the questions he put to our speakers. So may I think end there with my thanks to all of you, the thanks to the team, and to wish you all the very best moving forward, and that if anything, this will only build our determination, which you've seen here, to work together in the scientific community and the public health community to try and bring this pandemic to its long-term conclusion, and it is a long-term conclusion. I think for our next discussion, what I would love to have asked of you is, we are very short-termist in all this, and we do need to do the thought experiment of our longer-term future, of how we return to a different kind of normality, living with the virus. And I think just to give Ilona the last word, and I hope I've written this right, that we should be responsible for one another and the planet on which we live. Thank you all very much for your time, and we hope we'll see you all again soon. Goodbye.